Well, hello, I'm Dr. Sherman Silber, and we're going to do a Facebook Live again. And we try to do this every month and answer all kinds of questions, whatever questions you might have about infertility or reproduction. And it's the Silber Infertility Center of St. Louis. And we have a real treat tonight. We have Cara and her 10-week-old baby with husband. He's obviously a fantastic house husband. You can see that he has the nappy there on his shoulder. He's ready to absorb any drool. And he's really one of these modern men. You can see that.
Yes, definitely.
So we're going to answer all kinds of questions, anything you have. But right now, I want to get into Kara's story because it's very interesting and instructive. And how long have the two of you been trying to get pregnant?
I would say it was the last 7 or 8 years.
Mhm.
We've been married for 16, but we didn't really start trying until probably the last, like I would say, 7 or 8 years.
Yeah, that's
So a long-term, very stable marriage, and but you were trying since you were about 30 years old. Is that right?
Right. hmm
And nothing's happening. I mean, what did the doctors tell you? That's a long time to. You must have thought there was no hope.
Well, it kind of started back in 2018. I went in for a gynecologist appointment and they discovered a large fibroid. And so they,
Uh-oh.
of course, he's getting fussy. But they told me that we would need to take care of that. That was probably interfering with my ability to get pregnant. So we went ahead and it was so large that I had to do an open myomectomy. And then, of course, once they got in there, they found other smaller fibroids. So once those were all removed, they told us to try for about 6 months. And usually, once those were removed, you would conceive.
And you were young enough, they must have thought the fibroid was the only problem, really.
Right. Yeah. And so those were removed. And of course, 6 months goes by, nothing happening. And then they finally tested my husband and then found out that he had low sperm count and low motility. So those were issues as well.
You were a marriage made in heaven. Both of you were infertile.
Yeah.
We couldn't pin it on you. We couldn't pin it only on him. It was both of you.
Right. And so then at that point, we were in Austin, Texas while this was all going on. And so we had seen a fertility specialist, and then they told us obviously that IVF was our next option. And we were just really hesitant. We had, it threw us for a loop because we never thought that we'd have to do IVF.
Yeah.
So we ended up leaving Austin, and then we moved to St. Louis to be closer to my husband's parents.
Yay.
And, yeah, so they live here. And we were actually thinking about adopting because the IVF, I was just so scared of all the injections and hormone therapy and just everything, that you have to go through.
Miserable experience doing it the conventional way. Yeah.
Right. And so we were thinking about adoption. And then I told Chad, I said, why don't we just look into IVF one more time? And so we were researching, and then lo and behold, Dr. Silber is here in St. Louis. So we felt like it was kind of meant to be. We had the consult and we were really comfortable. We liked your approach. The mini IVF was very interesting to us.
Was that the difference for you? Because you were really not excited about all the miserable aspects of IVF. And was the difference that you saw we could do it without all that misery?
Yeah, exactly. And just the focus on more like quality of the eggs than just trying to get a whole bunch. That's really what kind of made the difference for me. I said, okay, if we're going to do this, I want to get the best possible, eggs and the least amount of hormones and injections. Yeah, just make the process a little easier and as pleasant as possible, I guess.
Yeah. And you were very smart about this. We wound up getting a blastocyst, but then you did another cycle, so you'd have more blastocysts before doing an embryo transfer. And I think that's good because now you have two more blastocysts. So you might not want another child until you're 40 or 42, and then your eggs won't be as good. But you've got blastocysts from when you were, I guess, 37 years old.
Yes.
So that was a very smart thing that you did, really. But
Yeah.
it was easier for you to do that, I guess, because this wasn't such a miserable experience.
Right. Overall, I was really surprised at how, I don't want to say necessarily easy, but it just wasn't as hard as I thought it was going to be. And so
Right.
that's why I'm like, sure, I can do another, round. We would have liked to have gone for more, but we kind of stopped when we had the three, we have 3 frozen embryos and
Yeah.
2 now, obviously. But we thought we had a pretty good chance.
I think you'll be okay with those two. At least one of them should be able to be a baby. So I think you'll be okay with that. So it looks like we lost Chad for a while.
I know. I'm sorry.
What a super husband. Fantastic. Uh, so you decided to do it IVF simply because it was a simple approach. And, the baby rate per egg is so much higher with this protocol that we may not get quite as many eggs, though we didn't get a small number of eggs. But the baby rate per egg is so much better that it's just the highest success rate. We originally started doing many IVF for the low prognosis older women. But now we're doing it for everyone because we think in any situation it's better, even if you were younger and had lots of eggs. It's easier and better. So you're living proof of that. So I don't know. Do you have any thoughts or questions for me now?
No, well, some of the thoughts were, I wasn't. The problems that I was having with those fibroids, they kept coming back. And so I just kind of wanted to touch on that in between the transfers and then, or actually the egg retrievals and then the transfer, I had to have an open myomectomy. That was my second one.
Yes, right.
And so that was a struggle because then I had to heal for at least like 6 months.
Yes.
And then start that process to get ready for the transfer. And then if you remember, about a week before we were supposed to do the transfer, I had a polyp that showed up on my ultrasound.
Right.
And so that had to be removed.
Right.
And luckily we were able to schedule that pretty quickly. And then we were told that it'd be several months before we could do that actual transfer. But I healed up so fast that we were able to do the transfer in September. I had the surgery in early August, and then we did the transfer late September. So
from polypectomy, you can heal remarkably quickly. So we often do the transfer soon after the polypectomy. I like to wait 6 months after the myomectomy.
Right. Yeah, we knew that. That was another reason why we kind of stopped at just the 2 egg retrievals that we did, because I knew I was going to have to heal for 6 months after that surgery, because we knew about the fibroids, before the egg retrievals.
Yes, right.
And so just knowing that, I was like, oh, I don't want to keep waiting and waiting. That's kind of what happens when you have to
our
do
approach that I explained to you, our approach is if you have fibroids, we don't want to delay the IVF just because we have fibroids. So we get the embryos. The younger the eggs are that they came from, the better, the higher the success rate. We freeze the embryos, and so we know we're not going to hurt them and they won't get older. And then we can take care of the fibroid or the polyp or whatever other problem you might have. But my philosophy is not to delay doing the mini IVF, because the younger your eggs, the better. And we'll have them frozen embryos. And if you have fibroids or polyps or hydrosalpinx or any other problem has to be taken care of, we can relax and take care of it. And we can wait the 6 months because we've still got embryos derived from younger eggs.
Right. Yeah. And it worked out great. I feel so lucky that our first one took.
Yeah.
I just remember when I went in for that transfer, you were saying we have good soil and good seed. So hopefully it'll take, just pray it takes. And so But I mean, yeah, overall, it was just a great experience. Obviously, I'm glad, we have the child now. So you're just like, I'm so glad we did this. But, even if the first one hadn't been successful, the process has been so great.
Yeah.
Everyone, like the whole team you've built, our coordinator, Liz, she was just so wonderful, like everything's so well organized, and we just felt at ease, like every step of the way, because it does end up being a long, journey.
That's great to hear because, when you go to a doctor's office and they're a mess and you can't get communication and everything's disorganized, that says something. That the doctor may be a smart doctor, but the patient really needs to feel that the whole team is organized and together and cares about them. So,
Right. And that, from the first consult, and then when we actually went in for our first egg retrieval, you were there, Dr. DeRosa was there. And I just, every time we had a procedure, you guys were both there, and just, made us feel as at ease as possible. It's always scary in those situations, but
you get two doctors because, my partner, Dr. Rose, and I both really care so much about this that it's rare when just one of us is there. Usually both of us are there.
right. Yeah. And that meant so much that, you both were there and reassuring us. And like I said, just making it, go as smoothly as possible for us. And because,
Yeah.
it's disappointing. Like I said earlier, you never think you're going to be in that situation. And, it's just happening more and more, it feels like. So just having someone to turn to that can help
I
you.
sometimes uh, get people to frown when I say this, and I'm being a little funny, but doing it the way you did it is the most romantic way to get pregnant. And that's because you really are working on it together. I mean, if it's a great relationship, like your relationship of 16 years, obviously is a spectacular marriage, uh, and you both had infertility problems, a marriage made in heaven. I mean, I think it really brings you together, solving the problem together. So people sometimes frown, but I think it's the most romantic way to have a baby.
Yeah, yeah. And thankfully, yes, we're a good partnership, and you need that. You definitely need that to get through IVF, I would say.
Well, that's right. Well, poor Chad, is he still with your little son, or is
Yes, I hear him screaming.
oh, he's screaming? Oh, okay. Well,
Hopefully he can come back.
okay. Well, okay. So maybe either you or I can answer. We can both answer questions. Uh, let's open up for questions. So, well, here's the first question. For patients considering IVF, what should they realistically expect in terms of the time commitment and number of appointments required? Well, actually, Cara can probably tell you we try to limit the number of appointments you need. We try to make it really, really easy for you. The last thing you want to do is be sitting in a waiting room with a bunch of strangers with something so intimate and so emotional as this. What did you think about, Cara, the number of appointments, and can you talk about that?
Yeah, it was very minimal, I would say. Just only the ones that were absolutely necessary. You felt like you had to go in. I think that limiting the amount of like ultrasounds and blood draws and all of those things, doing the mini IVF route is what helped, because I was still working at the time, but I felt like I could really still manage getting to all of those appointments just fine. So as far as the time, I know my protocols took about like 2 months to do, leading up to like the actual egg retrieval. So, just plan on usually about 2 months, I would say, every time you do a retrieval.
Some programs have you coming in every day, doing ultrasounds every day, and they make you do 3 IUIs or 6 IUIs before you do IVF, and then your eggs are a year older. And we try to avoid that, and getting a lot of sperm counts on the husband. We don't never have to get a sperm count on the husband because we do ICSI with all of our cycles, so we don't care if the count is high or low. And men don't like to come in and do sperm count after sperm count after sperm count. So the answer to your question from both Cara and me is we really try to minimize the time you have to come in and sit in a waiting room with a bunch of strangers on something that's very, very intimate. So let's have the next question. What are the latest advancements in IVF and many IVF techniques you use in your clinic? Oh, that is a really big question.
That's a whole discussion.
That's like a book right there. So, well, I guess there are several things I can talk about. One is that our freezing protocol now is so perfect. We just don't reduce the success rate. In fact, we increase the success rate dramatically with frozen over fresh. We were the first to introduce the modern vitrification technique to the United States. We work extensively with the Japanese on this, who are the masters of this. And I think our intimate collaboration with the Japanese teams has allowed us to really excel with vitrification and freezing. So let's say the husband sometimes he's been on testosterone and he has no sperm, and it might take 6 months for him to have sperm. Well, we don't want the wife's eggs to get older while we're waiting. Well, we can just freeze her eggs, and that's just as good as fresh because our egg freezing, which we pioneered, is just fantastically good and fantastically safe. So the freezing is fantastic. The other thing we're about to do, you've heard of the genetic testing, and the genetic testing, so to speak, isn't really genetic testing. It's really just counting chromosomes. We can't really test for 23,000 genes. No one can do that. And people are misled into thinking, oh, we'll make sure the baby's normal because we're doing genetic testing. You're not doing that. It would be nice, though, to be able to predict which embryos are more likely to result in the baby. The problem is the genetic testing up until now has been so inaccurate that we've discovered that many times embryos are thrown out with a diagnosis of being abnormal when they would have been a healthy, normal baby because there's so many errors with it. So now we're proceeding to use a different approach, not what we call comparative genomic hybridization and not with even next generation sequencing, but with what we call SNP arrays. So we feel we're going to be so much more accurate with counting chromosomes that we won't run the risk of throwing away embryos misdiagnosed as abnormal that would have been normal babies. So that's a fairly brand new thing. Also, with that approach, if there's a history in the family or in your family of cancer or heart disease, we can actually test for many hundreds of thousands of these genes and determine whether your baby, which embryo would have the least likelihood of having a proclivity towards that family disease of cancer, heart disease, whatever runs in the family. So it's a big change. We're not just talking about mutations. We're talking about, in general, trying to maximize the chance of having a baby that will not have some terrible disease later in life. So I think that's a huge advance. The advance we're working on now is, and we've done it in mice and we're halfway there in humans, is doing a skin biopsy on older women who've run out of eggs, turn the skin cells into stem cells, turn those stem cells into eggs. We've done this with mice. We have healthy baby mice from eggs derived from a mother's skin biopsy. Now with humans, it's still experimental, but we've gotten halfway there and made what we call primordial germ cells. We think it's going to take another 5 or more years to succeed in that with the human, and then another 5 years after that for regulatory safety testing. But this is based on close collaboration with our Japanese colleagues. We've been collaborating with them for 10 years on all of this, and we think that'll be available to the clinic in about 10 years. But we're using that technology to do in vitro maturation, which means when we take out an ovary to freeze it prior to cancer treatment, we can actually get eggs out of that ovary and not have to worry about transferring back cancer cells with an ovary transplant, because we can mature the immature eggs from the ovary with these same techniques that the Japanese have developed for making normal eggs out of skin biopsy. So that's just a few. We're also using AI for selecting the best sperm, and there'll be AI uses for many more things, like selecting the best embryos without even doing an embryo biopsy. Oh, long-winded answer. Sorry for the long-winded answer, but there's so many new things we're the forefront of. Okay, let's see. What is your perspective on age limits for fertility treatments, particularly concerning women using their own eggs versus donor eggs? Well, okay. Cara, you were what, 37, is that right?
Currently, or whenever I did the
Well, currently and whenever you did the
I'm 39 now,
yeah.
and so yes, about around 37 whenever we got the retrievals.
So what happens is between the ages of 35 and 40, the eggs undergo a fairly dramatic decline in fertility. So we can get women pregnant with 40 and 44-year-old eggs. However, the pregnancy rate is much lower. You have to use mini IVF to do it, but it's a lower pregnancy rate. So we think it's very important not to waste time doing stupid tests that don't do any good, or giving men hormones to try to increase their sperm count when all you have to do is ICSI with their low sperm count. The real problem is if you're doing stupid things that don't help while the eggs get older, you're lowering the couple's chances. So we really think that's maybe the most important concept in the way we do it. We don't delay. We are concerned about the age. Now the question is about the age. Our oldest patient with donor eggs is 62, but our oldest patient with her own eggs is 60, because she had frozen her eggs when she was 35, and then when she was 60 wanted a baby. And nowadays we're all going to live to 100. It's a different world that we're in. So these are very, very healthy, fit women that have a long life expectancy, and they really want to have children. So we don't have an age limit. Even if you're 50, we'll try it with your own eggs, but we tell you the chances would be extremely, extremely, extremely low. Most women, though, would not go to donor eggs unless they've given it a try with their own eggs, even if it's a low success rate. So even up to age 50 or 50, we will try with your own eggs if that's what you need to do. And who knows, we might hit the jackpot on some of them. But certainly 44, 42, 46 years old, we'll definitely do mini IVF with those women and get a reasonable success rate. Okay, Cara, I'm glad you did this at 37, though. But if you had waited another few years, you would have been a lower success rate category. So,
Right.
okay, can you discuss the significance of sperm quality beyond just count and motility in achieving a successful pregnancy, and how you assess it? Well, you've got to understand that we do ICSI with all of our cycles, because a sperm can look perfectly normal. Couple hasn't been getting pregnant, and when you do IVF regularly, you see no fertilization or poor quality embryos. So we invented what we call intracytoplasmic sperm injection. That means injecting sperm into the egg. So we do that with all of our cycles. Now we had to do it with Cara's cycles, because she had sperm count was really poor, and we knew that it wouldn't fertilize with regular IVF, but we always do ICSI. We don't try to diagnose whether the sperm are going to fertilize or not. With ICSI, we can pick out the very best sperm, and with AI now it's even easier, but we can pick out the very best sperm and inject those sperm. So we don't pick out sperm that look abnormal. We don't pick sperm that are not motile. Don't pick sperm that have broken necks, or macro heads, or tiny heads, or poorly shaped heads. We pick out the best sperm, and that's the sperm we inject. So it's another reason to do injection or ICSI on every IVF cycle. And we don't charge extra for doing the ICSI. We do it on everybody without an extra charge for ICSI. Hope that answers that question. How do you tailor treatment plans for PCOS patients, considering the diverse manifestations of the syndrome? PCOS, many of you out there have heard of it, and your doctors are confused by it, and you're confused by it. It stands for polycystic ovary syndrome. And it's so poorly understood, but it's so simple. we really understand how the ovary works because we've done ovary transplantation. We turn stem cells into oocytes. We really have dissected ovary and understand it in the human as well as in experimental animals. And so it's very, very simple. PCOS just means you were born with too many eggs. And that sounds strange, but women with PCOS have a later menopause because they have more eggs. But those eggs, when they're younger, inhibit the pituitary gland secretion of its hormones, FSH and LH. And so when you menstruate, that should go way up and you should recruit a dominant follicle. But PCOS patients just don't recruit a dominant follicle. They either don't ovulate or they ovulate late in the cycle or they have a poorly developed egg because the gonadotropins from the pituitary were not on an adequate level because that huge number of eggs inhibited the pituitary gland. And they usually have irregular cycles, not always, but usually, again, because of that inhibition of the pituitary hormones. And that's what causes PCOS. Secondary things, some women are overweight because it produces extra testosterone. It gives them a higher appetite. Many women have a high testosterone level causing hirsutism and causing oily skin. Those are all secondary things. The primary initiating cause of PCOS is very, very simple. Too many eggs. And the treatment is very simple. Birth control pills, 21 days on, 7 days off when you're not trying to get pregnant, and do mini IVF when you are. Why mini IVF? Because with all those eggs, you can have hyperstimulation syndrome and have dangerous results from the hyperstimulation. That won't happen with mini IVF. So the key to treating PCOS is mini IVF and then triggering maturation with Lupron, not with HCG. So we don't get any hyperstimulation syndrome. We haven't had it in 20 years since we started using mini IVF. So that's the simplest answer I can give you, but it really tells the story on PCOS. Let's see, how do you address the significant emotional and psychological toll that infertility treatment can take on individuals and couples? What support resources do you recommend? Okay, this I've got to throw to Cara. Cara, you've got to answer that question.
Right. I'll just start out, like I said, it kind of just throws you for a loop whenever you get that diagnosis of infertility, especially when you're ready to start your family. I know Chad and myself, we're very scheduled. We were like, we're both going to finish our degrees. That's why we started trying so much later into our marriage. And then it's really crushing whenever you get that diagnosis of infertility. So for us, I mean, we have a fantastic relationship. So just relying on each other and not blaming, that was the other thing, like really not blaming, each other because it's out of our control. We didn't cause this. So just really, like I said, having a strong relationship, leaning on each other, not blaming. That's what really helped us get through it. We have a lot of support from our families as well. I'm the oldest, so my parents have been waiting a long time for me to have children. So they were definitely for IVF, encouraging us through the whole process. But yeah, I would just say, and not giving up hope either. I know for us, I felt like there were so many setbacks with having to do surgeries and then getting prepared for a transfer and then being told, well, we're going to have to cancel and, start this process again. So, just not giving up hope. There's always hope. So just
now, I want you to add about what was it like dealing with the office with all of this emotion?
The office was great. We had tons of support. Dr. Silber, I just remember you saying, I know this is disappointing, but we're just going to move on from this. And that's all you can do. So, just getting, you guys were always very realistic and, being upfront with what we needed to do and just encouraging us to keep going. So
well, you're a great marriage and you're really an inspiration to everyone. So I'm so glad you were willing to talk about this on Facebook. You make, I'm getting goosebumps just hearing your talk. What a great marriage. I wish your husband didn't have to leave, but that shows what a great husband he is.
He is. He's back there with the baby, trying to calm him down.
Wow. Well, what a great marriage. You're an inspiration. And your children are going to be that way too, because it's those first few years of life that are really critical in determining personality and character and emotional stability and intelligence. And your kids are just going to grow up great. And I'm so thrilled to see you. So, but I think we have to close now. The time is up, and I want to encourage people. We can. All you have to do is call us at Infertility Center of St. Louis, and it's a free. I mean, Cara will tell you it's a free consult. We don't charge for consults.
Yes,
absolutely. Or you can email us at infertile.com and schedule an appointment. And you can see, I love doing this. I love meeting people like Cara. And of course, when we do the procedure, there are costs, but we try to keep it as low as we can. But there's no cost to the consultation. So just call up, and I love talking to you. So this is Dr. Silber, and this is Cara, and Chad just signing off for this month's for Facebook Live. Thank you very much.
Thank you.
Bye-bye.